I'm Izzah Tahir, a medical student at the Khan University and part of the Student Organizing Committee of the three ANOs. I will be introducing the chair and co-chair for this session. The chair for this session is Dr. Hina Hashmi. She's director of the Atomic Energy Medical Center, the pioneer cancer hospital of Pakistan Atomic Energy Commission, which is a dedicated radiation oncology setup in the premises of JPMC. She is currently working as the chief radiation oncologist and the supervisor of the FCPS radiation program. The co-chair for this session is Dr. Muhammad Khurram Minhas. Dr. Minhas currently works as consultant pathologist and assistant professor in the section of histopathology, Department of Pathology and Laboratory Medicine at the Khan University Hospital, Karachi. He is also professionally associated with the Pakistan Medical and Dental Council, Pakistan Association of Pathologists, and the Histopathology and Cytopathology Society of Pakistan. Dr. Minhas is an avid researcher, and his research interest encompasses the fields of breast pathology and hematolymphoid pathology. Welcome, Dr. Hashmi and Dr. Khurram Minhas. Over to you, Dr. Hashmi.
Thank you very much, Ms. Izzah, for a very nice introduction. It's a pleasure for me to be here to chair this session along with my co-chair, Dr. Khurram Minhas. We together warmly welcome you at the Pediatric Neuro-Oncology session of the third annual Neuro-Oncology Symposium here in the Khan Auditorium. The management of the pediatric brain tumors faces difficult challenges in our setup because of the limited treatment facilities available, lack of awareness, price of the treatment due to much morbidity and mortality of the treatment-related mortality and morbidity in these patients, and lack of capacity building. So it is an emerging need to address these issues in these forums and these sessions. Our session will comprise of 3 talks from the international and national faculty, and each speaker will be given 20 minutes. We request and anticipate that each speaker will complete in the due time. May I take the honor to introduce the first speaker. He is Dr. Michael Devon. He is an assistant professor of neurological surgery, as well as the surgical director of pediatric neuro-oncology and pediatric neurovascular program at the Monroe Carroll Children's Hospital at Vanderbilt and the Vanderbilt University Medical Center. After completing his neurosurgery residency at Vanderbilt University Medical School, he worked as a fellow at Harvard Medical School and then chief fellow in pediatric neurosurgery at University of Toronto. In 2016, he co-founded the Global Neurosurgery Initiative within the program in Global Surgery and Social Change at Harvard Medical School, which is now a leading center for international neurosurgical collaboration, advocacy, and scientific progress. Dr. Devon have published over 80 manuscripts, has a wide range of research interests, including clinical and translational neuro-oncology targeted treatments and outcomes, pediatric neurovascular disorders and surgical therapy, global epidemiology and treatment of neurosurgical disease, neurosurgical capacity building in low resource settings, and surgical management of congenital neurological disorders. He will be talking over the management of recurrent pediatric ependymomas to resect or not. Dr. Michael Devon, may I have the honor to invite you, sir, in this session. Thank you very much. Over to you, sir.
Thank you for that very kind introduction. So as you mentioned, I'll be discussing the management of recurrent pediatric ependymoma. But let me just say how honored and privileged I feel to be standing here today with you all in person. I promised Noreen last year that I would be present last year, and then all the COVID business happened. But I'm so humbled by the hospitality that you've shown, Dr. Thompson and I, over the last 24 hours. And I feel very fortunate to be here. And I do hope that this is just the beginning of a very long relationship, and that will build over the years. But I know that I'm on the clock, so I'll just get going. We're going to be talking about recurrent ependymoma and how we treat these patients. I'll start with some cases, and then discuss some of our experience with pediatric ependymoma, recurrent disease, and ependymoma. We'll talk about some survival data and some complications. But for starters, this is a 1-year-old girl who presented in 2017 with regression of milestones and vomiting, and she had this large anaplastic ependymoma that ultimately was resected completely, and she underwent radiation. And had a G-tube for a period of time that came out, overall did pretty well. And then 3 years later on surveillance imaging, she was found to have recurrent disease here that you can see in the region of the superior cerebellar peduncle. She underwent a redo resection that was complete. She was re-irradiated and got chemotherapy. And then almost a year to the date later, just across from the brainstem on that same side, she had another recurrence. That was resected. She did beautifully from that operation, underwent radiation yet again, and then almost another, 11 months after that, had another posterior fossa recurrence that was resected, and I've monitored her. That was the beginning of this year, and I saw her just a couple of weeks ago in clinic, and she's doing well. But I suspect that this is something, it's just a matter of time, likely, before this PFA ependymoma comes back somewhere. This is a very challenging disease, and I want to talk about the Toronto experience. I did my fellowship there several years ago, and met some wonderful individuals who deserve a lot of credit for the work that I'm about to discuss. Armand Malhotra in the top left, Peter Dirks, and Vijay Ramaswamy. So this is our Toronto cohort. Over 20 years, we looked at 60 patients with posterior fossa ependymoma. The mean age was about 5 years. As we know, PFAs are more common than PFBs. That was true in our cohort. All these patients underwent a resection, of whom the majority, about 60%, got a gross total resection. At index, after index surgery, a minority got chemotherapy, which is a shrinking minority, and the majority got adjuvant radiation. And this is just after index surgery, some of our survival curves. So at the top left, this is a relatively standard overall survival curve for posterior fossa ependymoma. You see a median survival around 10 years out. But we know how important is gross total resection at index surgery, and that's illustrated here in this center survival curve. The red representing the gross totals versus the blues that got a subtotal or near total resection. And then as important, if not more so, is the molecular biology. So these PFBs, which is represented by that blue line at the bottom right, that's a curve that could match a fully resected pilocytic astrocytoma. That's how big of a difference the molecular status is versus the PFAs that do not do as well. But I want to talk about recurrent disease, because I think that's where more of the debate lies. That was represented by 29 patients that had a mean time to recurrence of 2 years. There were 19 patients that had 2 or more recurrences, and a couple patients that had 7 that underwent surgery for a total of 7 times. And the vast majority of patients that the majority of patients that got surgery at their first recurrence underwent a gross total resection of that recurrence versus the others that you see there. The table at the bottom right, I include because I think it tells an interesting story about how we view these patients and how we treat them. On the left is the number of recurrences, and you can see next to that the number of patients. And from a surgery side, you don't see a whole lot of change between recurrence number 1 and number 7 in terms of the proportion of patients that are offered surgery. But what you do see is a decreasing proportion that get radiation, because these are patients that have been radiated 2-3 times already. These are young patients. And then the chemotherapy, you see the opposite, a relatively higher proportion of patients that are getting chemotherapy because we're desperate at that time. We're throwing things at them that we know does not have good data that supports their use, but we're grasping for things because these patients keep recurring. And this is the survival curve at the time after their first recurrence, and you see a much more dismal survival curve than at index diagnosis, which you see on the right of the screen. And so essentially, we know that when these patients recur, that they will have a challenging time over the subsequent years relative to their counterparts that never experienced a recurrence, and that's true for both PFB and PFA patients. This just demonstrates the survival curves in an unadjusted model based on the site of recurrence. So one thing that we wanted to know is, so if a patient recurs, did their extent of resection at their index surgery, did that matter? And what we found is it probably doesn't. And that's not to say that getting a gross total resection at the time of index surgery is not important. Indeed, that is hugely important. But it seems that once a tumor has decided to recur, it matters less what happened previously. What about the site of recurrence? Does that matter? Does it matter if they recur in the posterior fossa versus, say, in the spine or in the supratentorial space? And here we did not demonstrate a significant difference, but we certainly do suspect, and other data supports the fact that more local recurrence is relatively more favorable than a more distant recurrence, which follows logic. But essentially the question here, and what I want to talk about, is whether we should or should not be operating on recurrent and multiply recurrent disease. So let's take this boy here, 2.5-year-old with headache and ataxia, large left CP angle mass that ended up being a PFA. He got a gross total resection followed by radiation. And just a couple weeks after I did this case, he was in my clinic playing with the otoscope. He looked like nothing ever happened to him. He really did beautifully well. He did have an NG tube for a period of time, got radiated, and then just 6 months later, on a surveillance study, was found to have recurrence just in front of the medulla. And so this was early recurrence. Young kid, already got a gross total, got radiation. What next? Do we radiate him again? Do we offer chemotherapy? Do we do a redo resection? Keeping in mind that in this now 3-year-old boy, a redo resection here is a condylectomy, drilling down the lateral aspect of C1, mobilizing the vertebral artery. A not insignificant, not just a standard suboccipital craniotomy, but that's what we felt was the best thing for this patient and for his long-term survival. And he did great from this operation, and ended up getting chemotherapy as he'd been recently radiated. And so when we look at this question and we look at the data, should we be operating on recurrent ependymoma? The take home from this talk should be yes. That should be, ependymoma, posterior fossa ependymoma in kids at index is a surgical disease for sure. It remains a surgical disease after recurrence. And I really want to illustrate that here. Dramatic difference between those in this unadjusted model that get surgery versus those that don't. And what about the extent of resection? How important is that? Is that as important at recurrence as it is at index surgery? Maybe not quite as important, but it is important. And our data and some data that I'll show you from another group supports that as well. This is a study from China looking at 73 patients with recurrent ependymoma. What you're looking at there at the right of the screen is at the time of first recurrence. So the majority of these recurred in the posterior fossa. About half of patients got radiation, the other half did not, and about 40% got chemotherapy at first recurrence. But I think this is really the take-home image here or figure here that corroborates our data. So in the red, you're looking at those patients that got a gross total resection at the time of recurrence. And let's compare that to those that didn't get surgery at all. You can see that's represented by the black curve. You can see how dramatic that difference is. But even in those that got a gross total versus those that got a subtotal resection, there's a dramatic difference in that survival curve. And so again, should we operate on recurrent ependymoma? Yes, that should be our knee-jerk response, whether that's the first, second, third, fourth recurrence. And does extensive resection matter? It certainly does. I really like this nomogram because I think it also tells an interesting story here. So for the students, the way to interpret this, what we're looking at here is adding up scores to evaluate things like event-free or progression-free or overall survival. But on the left are the variables, and the horizontal distance is essentially the effect size of that variable on a given outcome in this situation, event-free survival. So what you're seeing here is, let's see if you can see my mouse here. By far the greatest contributor to overall survival and event-free survival is surgery. Next is radiation. Those that did not get radiation do worse. And then next is the molecular subgroup. And in pediatric oncology, how many times do we see that where the molecular biology perhaps matters less than a surgical intervention? But that is the case. That was the case in our cohort, is the case here. This is a surgical disease first, more than anything else. This is, again, looking at our data. What these figures demonstrate pictorially is where these tumors recur over the recurrences. So on the left, the first recurrence, then second recurrence, and then third recurrence. And what you see here is the size of those circles represents the number of tumors. Over time, the recurrences happen less and less in the posterior fossa, and more we see them as distant recurrences. And so you should ask yourself, well, then, if that's the case, do these re-resections, are they harder to perform, whether in the spine or other places in the brain, as opposed to just reopening an old incision? And what about the complication profile? If you're telling me that the overall survival is better, does that come at a cost, and what is that cost? And what I want to illustrate here is that, of course, surgery is a big deal and it matters, but these patients generally do much better than they did during their index surgery. So this is looking at the complications following primary ependymoma. In our cohort, about 10% of patients suffered cerebellar mutism, certainly less than the more midline medulloblastomas. About a quarter of them required shunts for hydrocephalus. 60% had one or more cranial neuropathies, a number of G-tubes and a trach. And that was for the primary resection. Okay, when we look at recurrent resection and what that complication profile looks like, it's certainly more favorable. No patients with cerebellar mutism. Again, these are different, a different disease altogether. Far fewer cases of cranial neuropathies, less G-tube insertions, and so the relation, and additionally, the relationship between extensive resection and complications is not such that we should be afraid to really go after and be aggressive with these tumors. What we didn't see was a dramatic difference in complications in those that got a gross total versus a subtotal resection. And it should embolden us as surgeons to really go after these lesions and try to get as much as we can. Extensive resection was not associated with the degree of postoperative complications, and there was no difference between complication severity in the primary versus the recurrent cohort. And really, it's At worst, they're the same. At best, the complication profile is more favorable at the time of recurrent surgery. So is survival benefit worth the risk of redo surgery? I hope that I've convinced you that the answer to that is yes. When you look at the survival curve between those that got surgery and those that didn't, on the left, combined with the fact that the complication profile is certainly, in our judgment, a favorable one, this supports an aggressive surgical philosophy in cases of recurrent ependymoma. So in summary, and again, mindful of time, the majority of PFA ependymomas recur. Okay, surgery remains the mainstay. It remains a surgical condition. We believe that getting a gross total at the time of recurrence is important. It matters just as it did during the index operation, and redo operations supratentorially, spinal, or in the posterior fossa can be safe and well tolerated. So we shouldn't be afraid to operate on these patients. So with that, I thank you, and I look forward to hearing from the other speakers.
Thank you, Dr. Dewan, for an elaborative talk on management of recurrent ependymomas. We'll take the questions towards the end of the session. I will now move to introduce our next speaker, Dr. Shahzadi Resham. She is assistant professor working at Khan University Hospital, and she is the lead person in establishing pediatric palliative care for our neuro-oncology and overall pediatric oncology patients. She has just come back after completing her fellowship at St. Jude's in pediatric palliative care. So I would request Dr. Shahzadi Resham to please come to the podium for her presentation. The title of her talk is Challenges in the Provision of Palliative Care in Low and Middle Income Countries Population. Thank you.
Good morning and Assalamu alaikum. Thank you so much for such a kind introduction. Thank you so much, Dr. Athar Inam, Dr. Noreen Mushtaq, and the team for giving me this opportunity here. So I'll be speaking about challenges in the provision of pediatric palliative care in LMIC and in Pakistan. I have nothing to disclose. We'll be talking about, and I would like to take this opportunity to talk about a little bit what is palliative care and how can we provide a high quality palliative care to our patients with brain tumor and their families, and then discussing the barriers in the provision of palliative care in low middle income countries and in Pakistan. So when we talk about palliative care, we think of two words, palliative, which means to cloak and to cover, like providing an additional layer of support to the families, to the patients suffering from brain tumors, and to the primary team caring for these families and patients. And the other word that comes in our mind is compassion, that came from come means together with, and pari, which means to suffer, like to suffer with the families and the patient. And as a part of our job is to take that suffering upon us as well. So WHO has defined palliative care as a holistic approach that relieves suffering by means of early identification, assessment, and treatment of not only pain, but also physical, psychosocial, and spiritual suffering. I don't want you all to relate this palliative care to the end of life care, because palliative care means to live well, and that can only be achieved by emphasizing on improving the quality of life. So when we think about our patients, we think of suffering. And for oncologists, the enemy is cancer. But for a palliative care physician, the enemy is suffering. And when we describe suffering, suffering comes as a key concept, which was described in the literature as a holistic form, and which means to provide holistic, multidisciplinary support to the families and integrating it early in the care of the patient. And when we integrate it early, It not only improves the quality of life, psychosocial outcomes, and caregiver burden, but also it can reduce the overall cost of care while improving the key quality metrics of care. So how can we provide high quality palliative care to our patient and family? God and Allah has provided us 2 ears and 1 mouth. So there must be a reason behind this. And the reason is to listen. To listen is to continually giving up on the expectations, but giving your total attention to the families without just thinking about what's happening in front of you, without thinking about what does it mean and what I'm going to hear from the families. To provide compassionate care, we talked this about earlier, and most importantly, multidisciplinary approach in a non-hierarchical manner. When I say non-hierarchical manner, it means that sharing all the voices coming from all the team members and taking them into account and not to shut them down. So what's the need of, and how much is the need of, the global need of palliative medicine? WHO says that 50 million are in need of palliative care in the last year of life. 78% of these deaths will occur in lower middle income countries. And 14% of patients requiring palliative care at the end of life actually received it. WHO has placed a great emphasis on implementing WHO World Health Assembly resolution that says about, that emphasize on revising laws and procedure about improving quality of life, training of healthcare professionals. And regardless of this high percentage of children needing palliative care in LMIC, there isn't enough data about the healthcare of the population living in LMICs and in Pakistan. Children and adolescents comprise 7% of total global palliative care needs. And on the basis of per capita, the need of children's palliative care is by far the highest in the region of Africa, followed by Southeast Asia, Eastern Mediterranean, and the Western Pacific. So what are some general barriers in the provision of palliative care in LMIC? I think which are similar to what in Pakistan, but so some of them are limited or lack of access to palliative care specialists or services, limited physician knowledge regarding the role of palliative care, physicians' discomfort in raising the topic of palliative care with the families, families' resistance to the involvement of palliative care or not ready to acknowledge incurable conditions, lack of home-based services, language is a barrier, uncertainty regarding the patient prognosis, time constraints of pediatric oncologists during consultations, cost of palliative care consultation and treatment, parent discomfort with possibility of hastening death, parents or staff discomfort with holding nutrition and hydration, communication difficulties between staff and families, and their fear of addiction with opioids. So beside all these general barriers, there are some specific barriers that have challenged our main components that are required for the development of palliative care from the WHO standpoint, which means lack of in policy, like lack of laws that acknowledge and define palliative care as a part of healthcare system, lack of national strategy on the palliative care implementation, lack of government support, and lack of clinical guidelines in the delivery of the services. Whereas in Pakistan, national healthcare policy has no provision for palliative care. There is no legislation, no regulations or national strategy for palliative care. It's been briefly referenced in National Cancer Control Plan. And for advocacy for its services and training, currently there's no palliative care association or regional palliative care network. Although there have been some effort made to have palliative care recognized as one of the subspecialty lately. Little or very less knowledge of healthcare providers about palliative care principles and practices. And this education is needed at 2 levels, at basic training levels for the healthcare professionals and the specialist training for the workers and the healthcare providers who are involved in the management of more complex illnesses. who will teach palliative care and who are doing research in palliative care, and also integrating it into the curriculum, training, and education programs. There's also a need to create awareness in the community with the help of media and public advocacy. And while caring for patients, it's very important to educate our patient and family about their personal care, about their symptoms, what to expect, how to treat, along with the signs and symptoms of impending death. In Pakistan, only 5 out of 101 medical colleges and 3 out of 60 nursing schools have integrated palliative education into the curriculum because of the dearth of trained or skilled workforce and limited funding for the specialty. Although College of Physician of Surgeon Pakistan have approved it as a approved pediatric palliative care fellowship as one of the fellowship program, but still our regulatory body, which is Pakistan Medical Council, does not mandate it as a part of the undergraduate or postgraduate curriculum. There's no official recognition for licensing or certification, and only a few advanced subspecialty programs. Workforce developmental issues, lack of professional training programs, shortage of inadequately trained palliative care workforce, limited collaboration between the healthcare organizations, and inadequate access to essential pain medications have been major barriers for the healthcare system challenges. Whereas in Pakistan, we have insufficient public healthcare infrastructure, lack of healthcare insurance, the public health services is unable to cater the need of very poor. And so the major population is forced to access private healthcare services. Medications, there's lack and dearth of and availability of medication required for palliative support, and lack of industry and pharmaceutical support. 87% of the population is paying out of the pocket, and more than 45% of the health budget is directed towards the curable diseases. Access to opioid for pain control has been a huge challenge in LMIC and in Pakistan. More than 80% of the world population lacks adequate access to opioids. Whereas in low middle income countries, they consume only 10% of the global opioids. However, ministerial declaration has reinforced its need and its availability and commitment to address the disparity in access of opioid. There is enormous variability in consumptions per capita around the world. It has been published in the literature about the need of consumption for 188 countries. They took the average from the top 20 from the Human Development Index, keeping it as a reference point for the consumption measure, which shows that the 83% of the countries have low to non-existent access to opioid, whereas 4% have moderate access, 7% have adequate, and 6% of the countries has insufficient data available. In Pakistan, the availability, we have a poor availability for opioid. We have regulatory barriers and restrictions to opioids to present as a major challenge. We need approval from 4 different ministries, and restriction on dispensing and procurement. There are restrictions on dispensing and procurements, and it's only available for cancer patients. There is a fixed quota which is given to the federally designated cancer centers. So the specialties that can prescribe opioid are only oncology, anesthesiology, and pain specialists. The available pharmacotherapy for palliation is buprenorphine, which is an opioid antagonist. Nalbuphine, it's an opioid antagonist. Tramadol is a weak opioid. Tapentadol, it's a new drug, which is an opioid and a serotogenic as well, and some adjuvant analgesics. So beside all these barriers, are many patients and the families fear and avoid information related to that. Often a belief that even acknowledging one may die soon is harmful. Many cultures have expressly prohibited informing patients and families of their diagnosis and prognosis, but there is growing acceptance of the idea to share information. Finances have been the major challenge for these life-threatening illnesses. And in many countries, effective medical treatment may only be available to those who have the financial resources to pay for care. So in summary, it's still relatively new to healthcare system, particularly in LMIC in Pakistan. A public healthcare approach is needed to foster its development. All barriers can be overcome. There are existing resources available that can be adapted to the individual countries to fill in this gap. But what is needed is the will to do so, and to recognize that the lack of palliative care is a problem that leads to unnecessary suffering for the people or the patient and the family who are amongst the most vulnerable. Thank you so much.
Thank you, Dr. Shehzadi, for a very nice and comprehensive talk regarding the capacity building of pediatric palliative care in our setup. She had talked in detail about the challenges and the difficulties she feels in our setup due to the lack of the infrastructure, lack of the medical facilities available, the cost of the treatment, and so on, which need to be addressed at the high level. Now we move on towards our third and the last speaker of this session. May I introduce Dr. Salman Kirmani. He is a pediatrician and serves as a chair of the Division of Women and Child Health at Aga Khan University Hospital, Karachi. Dr. Kirmani obtained his MBBS degree from Dow Medical College and subsequently pursued a residency in pediatrics at Mayo Clinic. He also possesses board certifications in pediatric endocrinology and medical genetics. With years of experience under his belt, Dr. Kirmani has acquired various accolades, including the Mayo Fellows Association Teacher of the Year Award during his tenure as an assistant professor at the Mayo Clinic College of Medicine and Science. Having specialized in medical genetics, Dr. Kirmani's research interests include hereditary diseases with a focus on endocrine disorders. I warmly welcome Dr. Salman Kirmani, and he will be talking about hereditary brain tumors predisposing syndromes. Dr. Salman Kirmani, please, you're welcome.
Thank you very much, everyone. And thanks to the organizing committee for inviting me, and thanks to our wonderful guests who have traveled from the US. And, it's just been wonderful to see the audience here, lots of students, lots of trainees. I'm very passionate to talk about genetics because the geneticists are guilty at making their field look very, very complicated and almost like intimidating for the other medical healthcare professionals. And my goal in every talk I give is to try to make it simple and tell you that it's really not rocket science at all. Neurosurgery is far tougher. So that, respect. All right. So no conflicts of interest, no financial disclosures. I'd really just, very briefly and I won't go into details about lots of molecular mechanism. Primarily, I'll focus on the recognition of syndromes with brain tumor predisposition. In a previous version of this talk, I had lots of pictures and lots of details about the syndromes, but I don't want this to be a syndromology talk because I think most people don't remember, and then there's always references. So I think what I'll focus on is the brain tumor and the neuro-oncology parts of the syndromes and the specific, the differences that recognition actually makes to the management and the outcomes of the patients, which is, really going to be the focus. So, this is sort of cancer 101, right? So, or tumor 101, I should say, right? So if you are born with a genetic predisposition, typically a second hit occurs somewhere during your somatic life, and you will develop a tumor. And that is what I'm going to focus on, which is the hereditary syndromes. Whereas pretty much every tumor, every cancer is genetic in nature because there are mutations that occur at the level of the tissue. And there's been lots of advances in neuro-oncology on targeting those pathways so you can actually get better outcomes. All tumors are clonal expansions. It really takes one cell to develop that genetic abnormality, and then the daughter cells and the clones of that, cell will then go on to develop the tumor. In terms of all cancers, 70 to 80% are still considered sporadic. But sporadic does not mean that there is no genetic component. There probably is, but it's probably multiple other factors that come into play. About 15 to 20% of all cancers actually cluster in families. Here, we are yet to identify the genetic factor, but there is a strong suspicion that something is there. And about 5 to 10% are actually identifiable factors, single genes, or what we call Mendelian disorders, where you have, so neurofibromatosis type 1, for example, would come under this belt. So I think for neuro-oncology, that number of 5 to 10% probably is correct, and it's probably going to be in children. The number may be higher than on the adult side, because the brain tumor predisposition syndromes tend to cause tumors early in life. Most of these syndromes are inherited in an autosomal dominant fashion, which means that, if a parent has that syndrome or disorder, there is a 50% chance of it being passed on. But that doesn't mean that every patient that you see will have a parent with the disease. There is a phenomenon of de novo mutations which occurs, and that can happen spontaneously. So you may not get a pedigree like this that you're seeing. You may get something where it's just one single occurrence. That does not mean it's not a syndrome. It doesn't always have to be inherited. So that's a take-home message. The other thing is that there is a phenomenon of non-penetrance and variable expressivity. Non-penetrance means that you may actually have the mutation, you may harbor the mutation, but you may not develop any manifestation of the disease. So it's an all or none phenomenon. Versus variable expressivity, which pretty much occurs in every genetic syndrome, which means that not every patient is going to get everything. There may be a spectrum, and some may get milder and some may get more severe manifestations. And there is an age-related variability as well. The older you get, the more manifestations you might find in certain syndromes. Rarely though, and in our part of the world, it's not so rare, we see autosomal recessive inheritance of certain syndromes. And I'll mention one in particular towards the end. And this is because of the high prevalence of consanguinity or cousin marriages in our part of the world. So Pakistan officially actually has the highest rate of cousin marriages anywhere in the world. The range is from 60 to 70%. It may be as high as 80% in rural areas. And so we see a lot of genetic syndromes that are otherwise extremely rare in other parts of the world. And I keep telling my colleagues at Mayo that I feel like I'm doing a fellowship in recessive diseases, because you just keep seeing those syndromes keep coming back. Now, when we focus on children and brain tumors, we realize that any type of tumor happens more when there are malformations in other parts of the body. So there's something that happens at the regulatory level in fetal life that then predisposes to those tumors. And actually, it's been proven very nicely in multiple studies that, if you have an underlying syndrome, you may actually be predisposed to developing a tumor. And there's a number of genetic pathways that have been identified. And it's very interesting that the same genes that actually contribute to development or organogenesis later on in life, after fetal life, actually are the ones that control cellular growth at a different level. And so it's the gene is not monofunctional. It actually changes its function. And that's the beauty of alternative splicing and epigenetics, where, the expression of genes changes over the lifetime. And there's a huge field of interest of, the fetal origin of adult disease, where fetal influences, whether it's malnutrition or chemical exposures, or maybe even neurochemical exposures like stress, can have on future health of the human. Now, focusing on CNS tumors in particular, we know that only 7% of all CNS tumors occur in children, but 25% of all childhood tumors are actually CNS tumors. So it's a big chunk of pediatric oncology. And we do know that children with malformations, especially CNS malformations, have a higher CNS tumor rate. These certain tumors occur earlier in life, and some actually peak later on in life, like the intracranial germ cell tumors. This is a list of syndromes, not extremely exhaustive. I left out things like retinoblastoma, for example, or Sturge-Weber syndrome, which have more vascular components, and focus really on the more solid tumors that you will see. And the reason why constitutional mismatch repair deficiency syndrome, or CMMRD, is separate is that that is the only autosomal recessive condition on the list. This is NF1, and really most neurosurgeons have dealt with it. Most don't like it, because by the time the patient comes to you from a surgical perspective, it's not a pleasant surgery to do, especially on the peripheral front. I think on the CNS front, things are changing. So 15% of all NF1 patients will develop any type of CNS tumor. Optic pathway gliomas are quite common, but I'll go into a little bit of detail of that. It's actually quite a well-behaved tumor. It's not a bad one to have. And maybe the surgical experience is that you guys see the worst of it. But I think in general, when we follow the patients, most of them actually go away. You do see other types of tumors that are listed over here. But it's very interesting that the patient with NF1 tends to do better with these tumors compared to the patient without NF1. And that's been a universal experience all over. The MPNSTs are bad. If there's malignant transformation, that's usually bad news, unfortunately, and people are trying very hard to target those. So same thing with OPGs, better prognosis with NF1. Most actually regress spontaneously. And that's why I say, your ophthalmologist is a very good friend, because in a non-invasive fashion, they can monitor the complications of this tumor, and prudent use of MRI. Because when you do an MRI, what you actually find is this unusual phenomenon called UBOs, unidentified bright objects. And then you're compelled to follow it and then do another MRI and then another. So the field is actually a bit conflicted on this, but most neurologists and geneticists agree that, don't do an MRI just purely for a screening purpose to see what's out there. If there is a neurological complication that you're seeing, if the ophthalmologist is alerting you to something happening, that's when you do an MRI. Otherwise, the serial MRIs will just increase the burden on the patient for no good reason. And chemotherapy really doesn't work very well. It's mixed results. For surgery, it's really more on the cosmetic front for palliation in the blind eye, because that's really, one of those rare OPGs that gets to that level. You're supposed to avoid radiation because NF1 is in the, mTOR pathway, which is a radiation sensitive pathway. So you do not want to expose those cells to radiation, because you'll actually get more brain tumors that way. The general rule for the cutaneous neurofibromas is to leave them alone, although some cosmetic benefit with laser and surgical removal is there. I think things that are sort of on the collar, on the belt line, stopping function are the ones that people do go for surgery. But overall, these are more of a nuisance rather than an actual, medical or a surgical problem. The plexiforms, though, can be bad. They can be very well behaved for a long period of time. They're extremely slow growing, but they can be bad if they're in a particular area, such as in the neck or in the pelvic region and so forth. And if they can cause any functional problems, they can actually cause a lot of issues. Again, the general rule is to avoid radiotherapy, because NF1 is a radiation sensitive syndrome. And recently there has been advances in using MEK inhibitors like selumetinib, but it again has not shown a universal response. The response has been in select individuals. MPNSTs, if it gets to that point, the only hope of cure is actually a complete surgical removal, which can be hugely challenging, because these are very, very complex tumors that are in very, very inaccessible parts of the body usually. NF2 is quite a different syndrome than NF1. And the reason why I bring that up is because of the bilateral acoustic neuromas that are the hallmark of this disease. There are some overlaps with NF1, and I think that's why it was unfortunately named neurofibromatosis, because of some of the overlap with the skin and the skin manifestation essentially. But the biology is quite different, and the outcomes are quite different too. In NF2, the vestibular schwannomas are quite slow growing, but they can be very problematic, as you may have seen in your careers. And a lot of patients will have spinal involvement as well. The management is quite challenging. Other brain tumors occur as well. Meningiomas can be quite common. And I think the general rule has been, in any childhood meningioma, please think of NF2. And I think the acoustic neuromas will be the giveaway there. Lots of extramedullary tumors as well as intramedullary tumors. And it seems that, they do have overall a worse outcome than NF1 because the life expectancy tends to be about 15 years after the initial diagnosis. So they're tough tumors to treat overall. The rhabdoid tumor predisposition syndrome, also known as schwannomatosis, due to SMARCB1 mutations, can actually cause quite malignant tumors in other parts of the body. But the CNS manifestations typically are these atypical teratoids or rhabdoid tumors. And the schwannomas can be very hard to manage as well. They present quite early on in life. And, I've only had one patient with this, it's a tough disorder. The von Hippel-Lindau disease causes many other complications with regards to the eyes and the retinal angiomas, the cystic disease in the kidney, the predisposition to kidney tumors, etc., and so forth. But for the neurosurgeon, the main problem is the CNS hemangioblastomas, and they can be multiple. You do try for a complete surgical resection in most cases, and patients tend to do well if you get a complete resection, but they tend to come back, and they tend to be in the spine in multiple areas as well. So just a lot of surveillance and a lot of look into symptoms that are occurring and preventing neurological dysfunction. As far as I've been able to tell, gamma knife is not effective. There may be newer approaches that do help with this. The tuberous sclerosis complex, is a very interesting tumor predisposition syndrome because, again, it involves very classic tumor predisposition pathways, and these are gain of function mutations in that pathway. So lots of, the SEGAs are the primary tumor that everyone, associates with TSC. More recently, mTOR inhibitors such as sirolimus or everolimus have been shown to decrease the size of these tumors. And you go for surgery if these mTOR inhibitors are not working, and despite being on medical treatment, there's increasing size, so there's life-threatening, intracranial pressure complications. The Li-Fraumeni syndrome is one of the most aggressive cancer predisposition syndromes that we know of, because, again, it involves the p53 tumor suppressor gene, and that is sort of an endpoint in a lot of cancer predisposition at the somatic level. But if you're born with the first hit, that second hit occurs pretty early in life, and you get very, very early tumors. So the median age of brain tumor diagnosis in the Li-Fraumeni patient is actually 16 years. More than half of these brain tumors occur less than 18 years of age. And, lots of other tumors as well. So you're not just dealing with a brain tumor. A patient may actually be dealing with 2 or 3 cancers at the same time, or tumors at the same time. And you can see the lifetime risk. So it is sort of an unforgiving syndrome. And right now, there hasn't been any target that has been known to really effectively dampen down that p53 pathway, but people are working on that. The Gorlin syndrome is again a sort of a multi-systemic syndrome with multiple manifestations, primarily involving the head and neck, but other areas as well. The basal cell carcinoma is the classic skin manifestation, but they do have brain tumors. 5% will develop medulloblastomas quite early on in life. They tend to have a favorable prognosis if it's a desmoplastic histology. And typically you will, do the standard surgical resection with then chemo and radiation, and they can develop meningioma. So again, important to recognize that that may be the case. The P10 hamartoma syndrome or Cowden syndrome has a very classic brain tumor associated with it, the Lermet-Duclos disease with very pathognomonic manifestations. I am always intimidated as I put up an MRI image with neurosurgeons in the audience saying, if I get this wrong, it's going to look really bad. So I hope this is right. But anyway, these are, again, from a syndromic standpoint, they can recur, they can be tough to treat. This is an old historical term, Turco syndrome, and it's sort of falling out of favor, but there are a number of colon cancer predisposition syndromes that can be associated with brain tumors, typically medulloblastoma with FAP or the GBM associated with the constitutional mismatch repair deficiency syndrome, which I'll touch on in just a second. So, Lynch syndrome or HNPCC, hereditary non-polyposis colon cancer, is your classic DNA mismatch repair syndrome. So DNA mismatch repairs can happen. One nucleotide just mismatches with another, and your body has a remarkable mechanism to just quickly repair it before cell division occurs and clones are formed. And when that happens, all is hunky-dory. But if that repair does not happen, or if your mechanism is deficient, then this will, cause, colon tumors, endometrial tumors, other tumors. The CNS tumors that are associated with this are multifold, as you can see, and the Danish registry study shows that 14% of Lynch families actually will have brain tumor. Mainly it's associated with MSH2, but it can be others. Individually, if you look, it's like 2 to 4% risk, but the Danish registry actually put that up at 14%. For the Pakistani context, CMMRD is very important because of consanguinity. So you have two individuals with Lynch syndrome who have a child together. They can then pass on both the mutations in a recessive fashion to their child, and then this child has CMMRD. They actually get misdiagnosed as NF1 because they have cafe au lait macules, but their brain tumors and their other tumors are extremely aggressive. They actually get colon cancer in the first or second decade of life. They can have multiple problems. The cafe au lait spots look just like NF1, so you have to be very, very careful. So I always take a very, very complete family history, and sometimes you need to do screening colonoscopies on the parents if you think that that's the case. The mean brain tumor age is very, very early, as you can tell, and lots of different types of tumors that happen. Again, there have been advances in targeted therapy, and our colleagues in Sick Kids Toronto have really led the way, and there's an international consortium that we're part of as well, where we're trying to find the cure for these disorders. So the case I'm trying to make at the end is that recognizing what syndrome you're dealing with will actually help you take better care of your patient and actually improve outcomes. We've seen with NF1 how they tend to do better. You actually need to be less aggressive maybe with certain tumors. You can actually target the pathway like with MEK inhibitors, et cetera, and so forth. Genetic counseling becomes extremely important. You can prevent an occurrence in future generations. So it's really, really important to recognize it. This slide makes it to almost every talk I give, and I'm pleased that whenever I change the year, I also change the amount. So what I'm saying is that the first genome took 13 years and $3 billion to be sequenced. And now you can sequence a human genome in less than a day, and it's going to be less than $200 shortly. And in 2024, they're claiming you're going to have the $100 genome. And that's really going to be fantastic. And so we're able to diagnose these individuals now very, very cheaply, very, very quickly. Even for an LMIC like Pakistan, we're outsourcing most of our genetic tests, but we are able to give them a diagnosis in 4 to 5 weeks. And it's been a phenomenal game changer. You have genome sequencers the size of a USB stick. You can go out into the field and really put a drop of blood on this, put it on a USB stick, and all the computing occurs up on the cloud. So you're going to get results in real time now. It's really going to be fantastic. So take home message is that we know at the tissue level, this is going to be the game in brain tumors. But for these patients with the hereditary syndromes, they have a much more aggressive course than your standard brain tumor patient. So you need to take extra care to diagnose them and recognize them. And that, the screening protocols and treating protocols are always being updated. So the clinician needs to be up to date on the management of these disorders. These are some resources, and I'm happy to share these slides with all the trainees in the audience. And thank you very much. And I think we'll have questions at the end, right? Thank you.
Thank you very much, Dr. Salman, for an excellent talk on brain cancer-associated predisposition syndromes. And obviously, the challenge is to identify these families and to bring into the net for screening purposes. And that is something which is a huge challenge for all of us. With this, we'll conclude the session, and the floor is open for questions. I will request the participants from the floor to please ask questions directly, one by one, and they can raise their hands so that the microphone can be put to them. Thank you.
Thank you. All three talks were brilliant. I had a question for Dr. Dewan. Is RELA fusion positive testing done as a matter of routine in pediatric ependymomas? And is there a significant difference in the recurrence rate between PFAs and RELA positive tumors in your experience?
Yeah, thanks for the question. Only if they're outside of the posterior fossa, at least in our institution. And for this particular study, since we were talking about posterior fossa ependymoma, we didn't look at relay. Yeah.
Thank you.
Do we have any other questions from the floor or from the online participants? Please go ahead and ask.
Just to comment, in fact, for the RELA fusion, as Michael said, now it's changed into ZEFTA. So as Michael said, so this is again the supratentorial, not the posterior fossa one, because they are mostly like PFA and PFB. And the outcome of RELA positive or ZEFTA positive ependymomas are pretty bad. So that's the issue. So we have one RELA positive in our part of the, at ATU. And unfortunately, that kid was a disaster. So we have done 1 surgery, 2 surgeries, 3 surgeries, and eventually he died within 1 to 2 years, even after radiation. So it's pretty bad.
Professor Kirmani. So such a high rate of consanguinity in our culture. Should every pediatric brain tumor go through screening by geneticists like you?
My knee jerk is sure, but I think it's just going to be a lot of burden. So I think there are some basic principles of taking a very good family history, looking at the clinical features. A clinical exam is probably your best screen, and then certain imaging findings that should immediately trigger that, oh, this could be a syndrome, like the Lermet-Duclos, for example. So I think the answer is that your clinical skills and your history taking skills will, and there will never be enough geneticists in the country to serve the needs of every brain tumor patient. So I think my cautious answer is no, although as a research study, wouldn't it be awesome if there was a central repository and we were actually able to answer that question very, very objectively?
So I knew you would answer that. So I wanted to carry the discussion to this, that maybe we should write up some kind of an algorithm, a guideline, because neurosurgeons, we operate. What about history, right? No, I'm just kidding. We do a stress on history though also. But so if we have this kind of algorithm, that simple algorithm that we can put it on all clinics everywhere, and publish it also for, in Pakistan at least. And there's simple algorithm, we can follow that would help, direct those specific patients to you.
And we can make it data driven, and I think Noreen can,
So,
working on it.
Dr. Ether, that's an excellent suggestion. So we are in the process of making guidelines for CMMRD. So if you talk about the CMMRD, so like we have some unpublished data from AKU, and our rate of CMMRD is more than 52%. So that's a very, very high number. And it's not only present in the high-grade glioma, it's also present in our T-cell lymphomas. And in fact, the tumor board, the national tumor boards we are having per month, I can safely say that we can have like 2 to 3 or maybe lesser, like 1 or 2 patients every month, maybe some from NICH, some patient from Children's Hospital Lahore, some from PIMS. So, it's quite, so the numbers are quite increasing. In fact, it's not increasing, they are there, but actually we don't know because we are not taking proper histories and we are not, we are not checking them. So in fact, if I go back retrospectively 10 years back, some of our patients did have all these things, but we haven't checked. And then after 5 to 6 years, they presented with like a lymphoma patient, they presented with high-grade gliomas and they passed away. But when you take the history of the families and all those things, they have significant consanguinity, significant history of colorectal cancers, brain tumors at a very early age. So it's not uncommon.
So you do provide that extra safety
Yes.
net, right? Once the patient, but then
Yes.
not every neurosurgeon sends patients to pediatric oncologists.
So this is
So,
what
right.
we are,
Right, right.
advocating.
And if
that-
you can expand that CMMRD stuff for all pediatric
So
patients
the
as
good
well.
part is that with this collaboration with the national twinning, we are now able to, do all these testing and all these, so many of the centers are now part of the URI's consortium, the international consortium for the CMMRD.
Thank you.
I have a question about timing of palliative care consultations. And, as someone who takes care of patients with malignant brain cancers, as a surgeon, I know upfront that the timing to involve our palliative care teams should be upfront, early, but there are barriers to that for some reason. And I wonder if you could comment on the ideal timing and perhaps how to educate your colleagues about that.
Thank you so much. That's a very important and important question. As you have already said, the ideal timing is to integrate palliative care right at the time when you make a diagnosis of any kind of tumor. But when we talk about the challenges, especially in the LMICs, and I'm not talking about the high middle income countries, because as Dr. Saman also said, that it would be a lot of burden for a palliative care physician as well. So we have set up some triggers so that on the basis of what you can involve a palliative care physician when we talk about brain tumors. So besides all other tumors, so for brain tumors, there should be an automated palliative care consultation right at the time of making a diagnosis. Because when it comes to, although palliative care doesn't mean that you don't involve palliative care when the disease is curable. Because when a patient or the family is suffering from the life-threatening and the life-limiting illness, palliative care should be on board as providing an additional layer of support to the family. So for LMIC, start with the triggers and then integrated right at the time of making diagnosis. And for when you have enough palliative care physician and your workforce and your multidisciplinary team, ideal time is to involve right in the beginning.
Excuse me, I had a question. And my question is for Dr. Shahzadi as well. So my question is, Dr. Buffet gave a talk, and then Dr. Amar also gave a talk. And they were regarding different interventions, modified chemotherapeutic drugs, immunotherapy, targeted therapy, therapies that have changed and potentially made tumors which were some at one point 5-6 years ago incurable to now having cure rates as high as 55%, 40% in high income countries. So my question is, as a palliative care specialist, how do you make sure, especially for the children, because they cannot make their own decisions. How do you draw a line while talking and discussing the options with the parents that this is enough? Because there would always be a new therapy, a new drug, a new clinical trial where you can enroll, where they can enroll their child to. And then for LMIC especially, where do you draw a line in, for example, let's say financial constraints? Would you want to burden a family to such an extent where they are going through years and years of pain, not only for the child, but also hospital visits, also seeing their child grow, thinner and so how do you draw a line in, what is therapeutic and what is just very excessive?
Thank you so much. That's a wonderful question. When we talk about LMIC, as a physician or as a team member who is caring for, as a part of the palliative care team member, or even I would say the primary care team person, you do not draw a line for them. You sit with them because the goal is to take their goals into account. How do they want their child to be treated as? How long? And when is the point they would like to end the treatment? Of course, the conversation would be transparent and should be transparent with the families. But we as a physician, we do not draw a line. We explain families what's happening, what's the current scenario, what are the available resources, how much support a physician or a hospital can provide. And then you make plans and align their goals with your goals. So it's about them, it's not about us. I hope I was able to answer your question.
So are there any other questions, please?
I have a question for Dr. Shahzadi. I was wondering, in the Pakistani context and in LMICs at large, where you have your specialists concentrating in the urban centers, do you see a future in Pakistan and other LMICs where palliative care, particularly the counseling aspect of it, is shifted to community health workers? Or do you think it's important to have specialists as your first line of, or your first point of contact?
You. I'm actually loving this session and the questions coming from our young students. And of course, as I talked about, the ideal team that can provide high quality palliative care is a multidisciplinary team in a non-hierarchical manner. There should be a palliative care physician who can be a part of the team, but should not be leading the team. So any member of the team who has a little bit of training, in communication or in dealing with the families and the patients who are suffering with complex medical illnesses can provide palliative care, which can include a physician, a nurse, a practitioner, a social worker, a chaplain, and a spiritual care provider, anyone who has a training. So whether in the community or in the hospital setting.
So here we conclude the session. This is definitely an ongoing debate. I'm thankful to all of the speakers who did an excellent job and have given the state-of-art lectures, their valuable time, and they have shared their experiences with us, and especially the international faculty who had traveled from abroad to our country in these circumstances and had given their valuable time. I'm thankful to the audience for their kind attention. And I'm sure that this discussion will have been proved very fruitful for all of us. And I'm thankful to the management, the organizing committee, Dr. Athar Imam, Dr. Noreen, who have given us this opportunity and this platform for continuing medical education and enhancing our medical care. I thank you all for your kind attention.